Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good afternoon, one and all. I welcome you all to today's Navigate Medico CME program. I would now like to request Professor Umesh Kapil Sir, the Secretary of the National Academy of Medical Sciences, to deliver his welcome address.
Namaskar and good afternoon to all of you. My most sincere welcome to Professor Ram Chadda sir, who has very kindly consented to deliver this important lecture in the Navigate program. What we have is that the continued medical education for the doctors who are in the peripheral institutions, PHC, CHC, district hospital, there's hardly any chance and opportunity to update their knowledge in the common diseases which we see day in, day out. Keeping in this fact in mind, NAMS initiated the activity of Navigate program, in which we try to have the best of the best presenters to give a state-of-art presentation to update the knowledge of our doctors in the peripheral institutions, plus all the PGs who are studying in different medical colleges in our country. It's a rare opportunity to have a session from Professor Ram Chadda sir, who has pioneered in the field of spinal surgery and also has done a lot of work in the field of orthopedics and minimally invasive cosmetic and spine surgery in the country. I would just like to share that this activity, this CME is live streamed, and I understand from my IT department that 279 people have joined on the YouTube and they are participating in this CME program. What we do is that all the PowerPoint presentations made, all the videos recording of these sessions are being put up on the NAMS virtual library that is on the NAMS website, in which we have all the lectures. Since January 2023, we have about 45 lectures. They all are available and freely can be downloaded. My most humble thanks to Professor Raj Bahadur sir, who very kindly helped us in organizing these sessions, and which is large network of eminent people. We have got the best of the best speakers in the Navigate program. Sir, my namaskar and humble thanks to you for your help and blessings. I like to express my most sincere thanks to my colleague, Dr. Preeti, who is Assistant Professor in Department of Psychiatry at AIMS, for facilitating this scientific session and anchoring it. With these few words, I again welcome all of you. Over to you, Dr. Preeti.
Thank you, sir. It's a honor and a privilege for me to introduce the chief coordinator for today's session, Professor Raj Bahadur, sir, who is a project director and member secretary of the Regional Spinal Injury Center in Mohali. Sir is also the former vice chancellor of Baba Farid University of Health Sciences in Faridkot, and he's a director principal of GMCH Chandigarh. Sir has special expertise in general orthopedic surgery, orthopedic education, spinal surgery, and joint replacement. Sir has a vast experience in spinal surgery. He has done more than 11,500 spinal surgeries in a span of 19 years at GMCH and PGI located at Chandigarh, and 500 spine surgeries at regional spinal injury centers located in Mohali. He's treated around 330 major spinal injuries in the rural and border areas of Punjab. Sir had been awarded prestigious JJ Fellowship of Indian Orthopedic Association, British Council Fellowship at the Queen's University of Belfast, Fellowship of IGOF at Westphalen-Wilhelms University Hospital of Munster, Germany. Sir has also Fellowship of ASIF Switzerland and St. James Hospital, University of Leeds, UK. Sir has also been awarded the Young Achiever Award by Confederation of Indian Industry to talk with Tony Blair, Prime Minister of UK. Sir has multiple fellowships of national and international scientific societies, including the Fellowship of International College of Angiology, Fellowship of International Medical Science Academy, Fellowship of Association of Osteosynthesis International, Davos, Switzerland, Fellow of Indo-German Orthopedic Foundation, and Fellow of National Academy of Medical Sciences, and Fellow of Institute of Hospital Engineers. Sir has more than 200 research publications, chapters in books, and orations. It's a honor and privilege for us to have you here, sir. Over to you, sir.
Good afternoon, sir. At the outset, I'm grateful to the National Academy of Medical Sciences and especially to Professor Sareen, Professor Kapil, Professor Sood for organizing this program for the postgraduate students of our country in orthopedics. We had been doing these lectures for quite some time now. We have taken the topics on spine. Earlier, it was on pediatric surgery. And today we have very eminent person like Professor Ram Chadha from Mumbai, who would be speaking on lumbar canal stenosis. Before he takes over this topic, I would like to share with the postgraduate students of my country that our first qualified neurosurgeon of the country was Professor V. Ramamurthy at Madras Medical College. He was the first neurosurgeon of eminence at Chennai. So he used to do hemilaminectomy for case of the lumbar canal stenosis or for the disc disease. And then he had his next assistant, who was Professor Kalyan Raman. And he initiated that Professor Kalyan Raman to go to UK to learn the fenestration. And Professor Kalyan Raman, in his last lecture in the CME mentioned, which I am now trying to relate to you, so that you should have the basic foundation of this lecture. Professor Kalyan Raman went to UK and he has written that he was trained so much for doing the fenestration that he asked the nurse to do the planning for the surgery to finish by 3 o'clock because he wanted to go to see the movie. So he started his surgery at 2:30 and finished the surgery and went to see the movie. So that was the level of the training of Professor Kalyan Raman to do the fenestration and remove the disc. And after this training under Mr. Dot, he came to India back to the same department of neurosurgery under Professor Raman, and where he was still doing the hemilaminectomy. But gradually, after doing the fenestration, he has written in his article on lumbar canal stenosis that if a patient has a pain in the abdomen, I repeat, if the patient has a pain in the abdomen, he should not take a second to open the abdomen and do a very little inside the abdomen. On the contrary, if there is a pain in the spine, he should think, the spinal surgeon should think and rethink and rethink. Once he has decided to go inside, he must do elaborate decompression and a treatment inside the spine. So in cases of the disc disease, he has mentioned that in our country, the disc disease is also associated with lumbar canal stenosis. So if as a surgeon, if a particular person is trying to remove the disc only and he's not careful about the stenosis, which may be associated with this, the result of the surgery may not be very good. So one must understand that when you are planning to do the surgery for disc, we must ensure that the lateral recesses are also taken care by doing the decompression on the lateral side. And that is what is the foundation of the lumbar canal stenosis, which is existing in our country as compared to the pure disc. In addition, we have a lumbar canal stenosis. Since I am in the northern part, we have a fluorosis-like disease existing in this part of the country, and this also decreases the size of the canal. Even if there is a patient with a disc, patient may have stenosis also along with it. I quote two examples of very eminent person. One is very eminent orthopedic surgeon. I would not name that person. He got the surgery done under fenestration, maybe from outside the country, and still the symptoms, they were persisting. And when he came again, a fair long laminectomy was done, which relieved his symptoms. So mere doing the fenestration or a limited surgery may not be helping in our patient. We must ensure that we do adequate decompression. A very important chief minister was also operated outside our country for a disc disease, where after the surgery still complaining of the pain in the leg, which means that the stenosis is still existing on the lateral part of the foraminals. So whenever we decide, we must see that the lateral stenosis is also taken care along with the disc. With this, I will invite Professor Ram Chadha, who is a master in the spinal surgery, to give you a total detail of the lumbar canal stenosis and the disease per se. Thank you very much, sir.
Thank you very
Thank
much.
you, sir. I would now like to introduce Professor Ram Chadha, sir, who is the head of the department at Leelavati Hospital and Research Center and consultant at Jaslok Hospital, LH Hiranandani Hospital and Global Hospitals, Mumbai. Sir has more than 35 years of rich experience in the field of spine surgery. Sir has worked as a professor and head of Department of Orthopedics at the KJ Somaya Medical College and Hospital. He has also completed multiple advanced fellowships in orthopedics and spine surgery in France, Germany, Switzerland, and USA. He is the pioneer of MICOS, which is the minimal invasive cosmetic spine surgery in India, and developed thoracoscopic and laparoscopic surgery for spine deformities. He has recently pioneered robotic spine surgery at Navi Mumbai. Sir is the president of the Indian Orthopedics Association for the year 2023 to 24. He is a past president of the Association of Spine Surgeons of India, Bombay Spine Society, and the Bombay Orthopedic Society. He is a federation delegate for India at the Asia Pacific Orthopedic Association. He is on the editorial board of the Asian Spine Journal, the Indian Spine Journal, and the Malaysian Orthopedic Journal. He is a regular keynote speaker and guest orator at scientific conferences. Thank you, sir, for taking out your valuable time for this lecture. Over to you, sir.
Thank you very much, ma'am. With due respects and gratitude to NAMS, to Professor Sareen, Professor Kapil, Professor Sood, and of course, my role model, my mentor, my senior, somebody I have immense love, respect, and regard for, Professor Raj Bahadur. Namaskar, and thank you very much, sir. It's indeed a pleasure and a privilege to be here addressing a large number of the younger generation who's going to be our peers someday and who would now look up to us, but someday they would have their own proteges working with them. And this is a legacy that we deserve to pass on. Hence, when I was invited to make this presentation, I looked at it as an opportunity where I could share information which could then be churned into knowledge and finally crystallized into wisdom. We are in an era where we are always looking forward to tomorrow, because whatever we can do today or tomorrow has the letter O in it, which is now, and it shows opportunities and options. Yesterday and the past, we cannot correct. So let's begin with lumbar canal stenosis. What is lumbar canal stenosis? It is an aging process according to most, and a few feel it is related to a pathology. I believe the answer is both yes and no to the assumption, and let's move ahead to understand. Lumbar canal stenosis, according to many, at least till the recent past, was an aging process. The word aging, A-G-E-I-N-G, can be spelled with or without an E. I believe in spelling it with an E because the E means enthusiasm, and it is our duty as doctors, as surgeons, as clinicians to renew the enthusiasm that an elderly patient may lose when they get lumbar canal stenosis. What is the pathogenesis in the elderly? Discs degenerate with time. Discs are shock absorbers between vertebral bodies. They allow us flexion, extension, rotations around them. But over a period of time, the proteoglycan, the fluid within the nucleus pulposus, which is in the center, tends to dry out. The annulus fibrosus tends to thicken and get weak. And there's a narrowing or settling down of the disc space. The motion segment also gets impaired. Ligamentum flavum, which is the inner surface of the spinal canal's bony canal, also gets thickened and buckles at times, causing a direct and an indirect reduction of the passage within which the passenger, the spinal cord above, and the cauda equina below in the lumbar canal pass. When there is a disparity or a dispute between the passage you were born with, which has narrowed down, and the passenger, which remained the same size, the cauda equina or the nerve roots, we get symptoms of lumbar canal stenosis. There may be micro instability to begin with, and then a macro instability in the form of a degenerative listhesis or a degenerative lumbar scoliosis. Listhesis is a forward movement seen better on the sagittal X-ray, while scoliosis is a lateral bending seen better on a frontal image. What is the way that this disease progresses? Very often, over a period of time, things do settle and the back pain improves despite the disc having settled down or even disappeared. This occurs in about 20% of cases. However, 76% of our patients remain neurologically intact and never complain of anything. 83% of patients with early neurogenic claudication or bladder bowel symptoms, vesicorectal symptoms, deteriorate with a final poor outcome. And these are the people who need to be looked at as surgical and should not be overlooked by us. However, very often we tend to neglect these and are in a hurry to operate those who could be conserved. When then should we consider breaking the claudication cycle? Gentlemen and ladies, neurogenic claudication is known as pseudo or false claudication. It's a common symptom of lumbar canal stenosis because of impingement or inflammation of the nerves coming out of the spinal cord. Neurogenic means that the problem is from the nerves, and claudication is from the Latin word limp because the patient tends to feel a cramping or weakness in the legs. Neurogenic claudication should be distinguished from vascular claudication. Here, the nerves are getting involved in lumbar canal stenosis, While in vascular claudication, it's the blood flow which is being challenged. In vascular claudication, it's a circulatory problem and not neural. What happens in neurogenic lumbar canal stenosis? To the rightmost is a reasonably narrow yet open canal in the elderly. Towards the center is a very stenotic canal where the ligamentum flavum is hypertrophied and the canal is almost invisible, with the theca being squeezed from center, side, front, back, everywhere. And if you look to the left of the screen, you will see that there's not much in the center, but there are extra foraminal areas outside the main canal where there is stenosis in the lateral recess and outwards. Hence, while studying the axial cuts, which are more important than the sagittal cuts at times, we have to look not just at the center, but also at the lateral recess, which was being alluded to by Professor Raj Bahadur when he told us those two anecdotal situations. When should we break the claudication cycle? Much before the MRI era, we used to have contrast and we used to do something called myelography. In that, we used to see these contrasts and we used to see these complete blocks and these lateral root cutouts. It was very, very easy to analyze and review these things because this was a dynamic study. It was at times more functional than what we see on MRIs, which are static images. But the MRI is far superior because it gives us much more information beyond what only a myelography or a contrast-enhanced flow-through sequence would give us on plain films. When do we really have to break the claudication cycle surgically? After seeing the actual images, we also need to study the foramen in the sagittal plane and see if there is foraminal stenosis, as is noted here, and should be kept in mind that this is a normal looking foramen where the keyhole is completely seen in the parasagittal cut, while here the keyholes get obliterated by soft tissue, which is ligamentum flavum, which is causing foraminal stenosis, magnified and shown here. Thickened ligamentum flavum occupying the lateral recess. This is what on the previous image you would have seen was seen in an image here, which was lateral recess. So this is central and this is lateral recess. The lateral recess is better seen on a SAG image, looking for the keyhole and obliteration of the keyhole where there is foraminal stenosis. The characteristic symptom, as I've said, is spinal claudication. After having walked a short distance, the patient experiences severe pain not in the middle of the back, but in the buttocks, in the gluteal region, radiating down to the legs, giving numbness, cramping, weakness, tingling numbness. Usually, it involves both lower limbs. Usually, it is sort of symmetric, although one side may be more involved than the other. If these symptoms are tolerable and the patients do not affect what we call activities of daily living, ADL, functional capacity, or health-related quality of life, in this situation, the first line of treatment is always non-surgical, conservative. It would include pain medication, modification of activities of daily living, some physiotherapy and exercises, mild bracing with a little bit of forward flexion, because forward flexion actually opens the lateral recess and the canal a bit, allows people to walk more comfortably. You would have seen the elderly are far, far more comfortable stooping forward and walking. All our parents and grandparents at certain age do stoop forward because they are actually trying to overcome the lumbar canal stenosis by widening the canal and flexing a little bit forward. However, if despite all their attempts, we are unable to correct this, and the patient cannot tolerate this claudication, and the claudication distance and time becomes almost nil. Doctor, I get up from my bed, I can't reach the restroom. I'm finding it very, very difficult. Life is miserable just because of my buttock, thigh, and calf cramping up. These people need to be considered for an intervention. And of course, if there is that red flag of the bladder or the bowel with psychourethral symptoms coming in, specifically, women need to be asked. Women do not share this very commonly. Hence, it's our duty to check whether there is any early incontinence, which is appearing now. It actually makes the person find it to be a social stigma. They get a little bit asocial or antisocial because they're unable to live a clean, hygienic life. In such situations, we have to consider surgery. Surgery where we've tried everything for 3 to 6 months, minimum 3 months, maximum 6 months. If they don't settle, we have to offer them surgery. Always remember, if a patient walks into your clinic, has not been brought on a wheelchair or on a stretcher, you have 49% of the share as far as the informed shared decision making is concerned, while the patient and the caretaker has 51%. However, if bladder bowel gets involved, they are brought on a wheelchair or a stretcher, there it becomes 50-50, and it's your duty to forewarn them that non-surgical intervention may also be deleterious to their health. Having said that, persistent symptoms with reduction of quality of life, despite non-surgical care, progressive neurology, especially bladder and bowel, surgery needs to be offered. What surgery do we offer? We have to do a good decompression. As very rightly mentioned by Professor Rajbal, decompression is not just removal of the disc, it's removal of everything that is causing neural or thecal compression, central and lateral. Hence, if during this process of decompression, at any stage we feel we have destabilized the spine, that means we've made a stable spine less stable or unstable, we have to add fusion to that unstable situation. Hence, decompression with or without fusion is the way forward. I began by saying that is it purely an aging process or can it rarely be a pathology? I am now sharing with you an entity which is getting more common, more visible, and I see it in youngsters. I've even seen it in teenagers, which mimic the elderly. What is wrong? We may not know the cause, but we are finding that these situations are happening in the young. Two lowest mobile segments degenerated, occupying a space in the canal. This is just the early phase. See how it progresses. 3 contiguous levels, let's call them L34, L45, and L5S1, all having degenerated discs, large protrusions, early extrusions, if you see the other images, within the canal. How do these patients present? Well, I share with you a young man whom I treated more than a decade back. He was a young businessman, 26 years of age, did weight training as a passion. Most youngsters do that today. He was a marathon runner. He used to come regularly to the city of Mumbai and run the marathon in the first week of January or second week of January every year. He had back pain, which was slowly worsening for the last 3 years, which means from the age of 23. He had some left leg pain for 1 year, which was slowly worsening. He says that he quit smoking at the age of 20, which means I don't know when he really began. However, this time when he came in and I had been treating him for a couple of years, he did not have just claudication. He did not just have paresthesia. He had a weakness in the left L5-S1 nerve root areas, dermatomes and myotomes. And above all, he had the red flag sign in a 26-year-old of urgency of micturition. This is where the tentacles came up. This is where we had to think differently this time. What did I do? I had plain films, X-rays, AP and lateral views of the lumbosacral spine. I had an MRI, but did I need anything else this time? Yes, I did. I did dynamic lateral flexion extension X-rays to see if any micro or macro instability had set in. I also studied the sagittal and the axial images T2 and T1 weighted. I checked the lower three levels, and I'm showing you the most affected part of 3-4, 4-5, and 5S1, showing a large posterocentral L3-4 with a small left foraminal L3-4, a left paracentral L4-5, and a much larger central left paracentral L5S1 going into the foramen as well. So there were three contiguous levels, all affecting the left side more than the right, and unfortunately, having symptoms which somewhere were now causing a vesicourethral challenge. Since I always do this, this is something like a degenerated disc disease in a youngster causing secondary canal stenosis to that degenerated disc disease. I studied the rest of the spine. The rest of the spine looked pretty good. It wasn't too bad. The entire cervical spine, thoracic spine, thoracolumbar spine. But the lower three levels seemed so much older than the rest of the spine. What to do next was my question. With the vesicourethral challenge, we had to do all these things in a hurry if we had to do it, because this was the time, after multiple consults over the past few years, he himself said, "Doc, I think we need surgery." Could I have done a CT scan? Yes, I could have, to check whether these discs had any calcification in the annulus. I could have done nerve conduction studies, could have done discography to find out which of these is the major offender as regards pain, could have done diagnostic root blocks to find out which of these nerves really need to be decompressed and which could be lesser decompressed if I so desire. Could have looked for some other cause for this degenerated disc disease by doing an RA factor, an anti-CCP, an anti-nuclear antibody, or an HLA-B27. Could have and should have done the vitamin D3, B12, HLA-B27, RA, anti-CCP, uric acid, and HbA1c. Yes, we did all that, but that did not defer or deny or delay surgical intervention this time because bladder was getting challenged. Now we had to think all the way around. Was non-surgical an option? Both the patient and I this time decided no. Now surgical. He's 26 years of age. What options do I have? If I decompress and fuse all his levels, he'll have a very, very stiff spine at the rock bottom. If I do an incomplete job with regards decompression, well, he'll have a stable spine, but he will have residual claudication or lateral recess stenosis, which may still bother him. So it was a complex situation. What next? Well, the three most important things that you need to do whenever you have a problem like this: counsel the patient, and counsel the patient. Informed, shared decision-making is an integral part of management of any of these patients. What did I do? Well, I sat down and looked at things the other way around. Normally, we decide what we are doing. We are going to do a lumbar decompression. Then we decide how we are doing it. Am I going to do it minimally invasive? Am I going to do it with a tube? Am I going to do it with a robot? And then finally, we decide why we are doing it. Friends, decision-making has to be the other way around. We have to first decide why we are doing the operation. Each and every aspect has to be reversed. Why? That means what all are the areas that we need to correct. Why are we doing it? Why are we doing it at L5S1? Why are we doing it at L45? Why are we doing it at L34? Why are we not doing it at L23? How are we doing it would be next. And what are we doing would be finally just the execution or the icing on the cake. That's the way we began, and that's the way we went ahead. What options did we have? We had option of doing just a fenestration and a discectomy. We had options of doing more than a fenestration where we removed part of the lamina called laminotomy. We had the option of doing an interlaminar discectomy, or we had the option of doing a complete wide laminectomy. Having said that, we also had options which were unusual at this time, but were available, called the non-fusion options. What are non-fusion options? These are options where we do not necessarily stop movement across the vertebral bodies. We allow physiological movement, but we prevent any pathological movement. In this patient, would I think of an interspinous bracer or a transpedicular soft option as seen here? Here is a soft flex rod which allows some movement, but not supraphysiological movement. Or we could put them inside between the spinous processes, like this, called a diam, which goes in between the spinous processes and allows some movement, but does not allow complete movement. We unfortunately had lost the option of a disc replacement because it got withdrawn a few years prior to this. And we were stuck with either the interspinous or pedicle-based soft options on one side, which could maintain the movement interbody, or do what is called as a fusion. In a fusion, we can remove all the compression, but we lose movement between the vertebral bodies. Hence, there was this big quandary. What should we do? How should we do it? Why are we doing it? Finally, we decided on doing something as a hybrid option. We decided that the lowest level we shall fuse, make it rock solid. 5 and S1 will be made one. 4 and 5 will be a non-fusion stabilization, allowing physiological movement, but not supraphysiological. And 3, 4 will be only a decompression, where the nerves will be freed, but we will not be putting any metal work. Hence, what did we do? We put screws into 3, 4, 4. We didn't put anything in 3, 4. We did a decompression here, micro decompression. We put screws into 4, screws into 5, and screws into sacrum or S1. The 5S1, we put in a spacer made of peak polyethyl ether ketone by a process called the T-lift, which I shall be talking of later. Here we had a mobile option, which is a barrel in between, which is called isobar TTL, which allows some movement between 4 and 5, L4 and L5, while L3, 4, we just did a micro decompression without metal work. So there are 6 screws, 2 rods. These 2 parts are mobile parts of the rod. These are immobile parts or solid parts of the rod. And this spacer has bone graft in it. This is the immediate post-operative X-ray. You can see the skin staples there, midline. And this is the patient at 7 years. He continues to run the marathon all over again. After 3 years, he started, has been running ever since. And where we are today is almost 10 years post-op. He is maintaining his lower lumbar sagittal balance, and he's got a good L3, 4 and a good L2, 3 levels with no adjacent segment disease. What have we learned? From this, we have learned that we have to treat the man and not the scan. The human being is far above what the MRI shows. Treat the signs and the symptoms he has with least invasion. Use the principle of miracle, which is an acronym. Minimal invasiveness, risks, and cost having a lasting effect. Now I move to lumbar canal stenosis plus. What is lumbar canal stenosis plus? It's also called complex lumbar canal stenosis. Besides what we see on the X-ray and the MRI, in certain patients, we see a bit more, which is an instability more than what we see in the standard primary lumbar canal stenosis. Here, it includes degenerative listhesis, where one vertebral body, like in this case L4, is slipping over L5. It's called a prolisthesis or just listhesis. If it moves back, it is called retrolisthesis, less common. This is degenerative scoliosis, where there is an angulation of the lumbosacral spine, again because of aging. As we age, we eccentrically load and eccentrically degenerate. So one side of the spine gets concave while the other gets convex. So this is degenerative scoliosis. And rarely we get secondary lumbar canal stenosis years later after a successful spinal surgery. This can happen, and all these are called lumbar canal stenosis plus or complex lumbar canal stenosis. Why do I call them complex lumbar canal stenosis? Because if you look at them long enough and critically look at their images and at the patient, you realize that they have an instability which is not obvious. Like this screen, if you look at for some time, you'll start seeing movement on a static image. How do we actually make it more visible? We make it more visible by either doing flexion extension X-rays called dynamic X-rays. And if you have a standing MRI, which is rare as yet in our country, but is available overseas from a company called Phonar, you can do a flexion extension MRI, which will actually cause an aggravation of the canal stenosis and flexion or forward listhesis, prolisthesis. And at times, even an extension can cause an aggravation of the prolisthesis or degenerative listhesis, worsening the canal stenosis. How do we address these degenerative listhesis or complex lumbar canal stenosis? Most of them need decompression with stabilization. Why? Because they have an established instability. I am walking you through surgeries done over the last 20 to 25 years. This is something which we used to do about 15 to 20 years back, where we had this device which used to go into the interbody space in place of the disc and open up like a flower. It was called the B-twin device, which I used to implant. And we used to put in 4 screws, and we used to put not just graft in the interbody space, but we used to also put graft in the posterolateral gutters, as we call them, in the intertransverse area between the transverse processes. Corticocancellous graft harvested locally from the surgical site or from the inner side of the iliac crest through the same incision. This is very, very important if you want to do a good fusion. However, we realized over a period of time that when we are putting interbody and intertransverse, the interbody fuses while the intertransverse disappears. This is post-op. This is about 3 months. This is 6 months, and this is 1 year, where the intertransverse graft, which was put in on day 1, which you see here, has almost disappeared, but the interbody has fused on CT scan. Hence, now when we are doing interbody work, we don't do intertransverse, and we do intertransverse where we are not doing interbody. Now coming to the second, which is a degenerative scoliosis, also called complex lumbar canal stenosis, but the angle or the degree or the COBS, as we call it, is less than 20 degrees, plus the interbody movement is not very significant. Between L3, L4, L4, L5, there's not much of a listhesis. It's more of a degenerative scoliosis. These patients will have a central and a lateral canal stenosis. So we would do a central and lateral canal decompression with a stabilization and posterolateral fusion. Here we may not do any interbody work, because we don't need to do either an interbody decompression or an interbody fusion, because there's not much of interbody movement. There are certain degenerative scoliosis where the angle is more than 20 degrees, or the COBs that you see here, significant angle, and there's a significant movement between 3 and 4, 4 and 5, retrolisthesis, prolisthesis, gross movement seen in these three films, which are in three different sagittal positions of an X-ray. Here we need major interbody work to be done in addition to putting in screws and rods. So here what do? We would put in 6 screws, 2 rods, and 4 spacers, 2 in L34 and 2 in L45. Hence, we've corrected with a short segment, because this is really short for a significant curve, but significantly corrected the L34, L45 instability and compression that you see here. And this is the way to go if you're doing degenerative scoliosis more than 20 degrees in the elderly. Coming to those redo surgeries where things did not go well after a period of time. This was 2 years after a microlumbar decompression. And this patient had back pain along with leg pain, and hence patient needed more than just a revision decompression. So we did a revision decompression with a one-sided approach, because the compression on the second time was also only one-sided. Went in, cleaned it up completely, and put in a spacer only from one side, the same B-twin from that one side alone. There are times when, unfortunately, you have done many years back an uninstrumented decompression alone. On table, it appeared stable. You didn't put in screws and rods. But many years later, patient came back with an instability or an iatrogenic listhesis. Here, when you have to revise, the patient has been happy for 3 to 4 years, then got reactivation of symptoms. Patient will come and say, Dr. Saab, please do the operation again, the same one that you did last time. No. This time it's more than what you did the first time. Your instability has come in. If you see here, these two vertebral bodies are slipping one on the other. This is the same patient who earlier had no slippage. But this patient is now 4 to 5 years down, and we have to look at doing the surgery because she has been unstable for quite some time now. And we then decide to do a revision decompression, but also do an instrumented fusion. There are some times where the instability is more than one level. Patient has severe osteoporosis as well. How do we address such a situation? Well, we delay things, we build up the bone, we improve quality of bone by giving anti-osteoporotic medication. Today, we have everything from bisphosphonates to denosumab to teriparatide and the new kid on the block called romosozumab. So we have everything from anti-resorptives to anabolics. We have our gynecologists helping us with MHT, which is menopausal hormonal therapy, or SERMs. Having done all that, if the patient needs surgery and the DEXA is still poor, in that situation, I would use special screws. I would even use teriparatide to build up the bone for some period of time. And I would at times use RHBMP2, which is a bone morphogenic protein, which enhances bone healing locally if you use it in the posterolateral gutters. This is when I talk of fragile bones, the very elderly who still need surgery. You have to use a combination of biologics on one side, which is teriparatide synthetic parathormone, monitored by a DEXA, and on the other side, you have to use mechanical supplements like cement augmented screws, wires, and bands. And of course, RHBMP2 with its riders there can be used sparingly and with caution. Whenever we have instability needing fusion, earlier we just had posterolateral and interbody fusion, which was posterior lumbar interbody fusion. Now, besides posterolateral and PLIF, posterior lumbar interbody fusion, we have transforaminal lumbar interbody fusion, which has become the gold standard. and we have an anterior A-lif or an O-lif, oblique or anterior lumbar interbody fusion. So today, besides posterolateral fusion, we have posterolateral lumbar interbody fusion, transforaminal, extreme lateral, XLIF, oblique lateral, and anterior lumbar interbody. In all these situations, which one do we use when? Well, it starts with Y again. Why do you do what? You do an interbody fusion because you stabilize an unstable, painful motion segment, and you correct a deformity, which could be a listhesis, a scoliosis, or a flat back. You would aim at a direct decompression with or without an indirect decompression. What is indirect decompression? Indirect decompression is where you are actually not physically removing the compression, but you're widening the canal, which is the lateral recess, by jacking up the height, either putting interbody spacers or putting transpedicular screws at the rear, so that the foramen, which is narrowed down, can be slightly widened and opened up. So the passage for the passenger is opened up. The cylinder is made wider. So beginning with the very beginning, where do we use posterolateral fusion alone? Here, can you see there are screws with bone graft on either side, corticocancellous. Certain decompression in the front, bone graft at the side. It works well for multi-segmental degenerative disorders, as I showed in my less than 20-degree curve degenerative scoliosis. It also works well in monosegmental low-grade instability, single levels, but not severe or gross mobility. It should not be used in the very tall discs or those with gross instability. Where there is gross instability and tall discs, we need to put a spacer either in the form of a bone graft, tricortical, or a bone graft within a spacer. The spacer could be titanium metal or PEEK, polyethyl ether ketone. There are other materials also available today, like tantalum and many other, silicon nitride, which have been tried, but the commonest are titanium and PEEK, polyethyl ether ketone. We have to retract the theca or the cord or the cauda equina, whatever you may call at the level, to gain access to the interbody space from the rear. This is to show you pure bone graft in the interbody space, which is what can be done. This is PLIF. It works best in high-grade spondylolisthesis or degenerative scoliosis, which needs significant correction. I showed you those between cages in a curve more than 20 degrees. Or in postoperative discitis, where we also put bone graft, at times with and at times without spacers. It is avoidable if there are unilateral symptoms where a lesser procedure, which I'm going to describe next, is used. It's also not commonly used where there are root anomalies on one side, so you have to go only from a single side. Sometimes there are duplication of roots or conjoint roots where you cannot retract the nerve root. In all those situations, we use the gold standard today, which is called transforaminal lumbar interbody fusion. Here, the graft is placed in the posterior interbody area within or without a spacer, in front of and inside that spacer, which is nothing but a cage or a mesh into which this goes, with additional instrumentation from a single one-sided pod. The side that you're putting the spacer, you have to sacrifice a part of the inferior facet of the upper vertebra and a partial decapitation of the superior part of the lower vertebra to make a tunnel or point of entry for this spacer. This is called transforaminal because you're actually making a small foramen much wider and you're putting the spacer through that. So this is the access to the disc where you've taken off the lower part of the part bone above and the upper part of the facet below and gone in, identified that disc and put that spacer in from that side without retracting the nerve root significantly. This is today the gold standard because the neural injury is also much, much less. And the post-operative neuritis, neuralgia, neuropathies are significantly less by the transforaminal lumbar interbody fusion. Here I'm showing 4 screws, 2 rods, and a titanium spacer in the front, which is the standard or the gold standard of a TLIF. Now coming to the latest kid on the block called the oblique lumbar interbody fusion. Here the screws are put from the rear or behind, while the spacer is put from the front, which is retroperitoneal, transabdominal from one side. It's an anterior oblique to the psoas without violating the muscle fibers of the lumbosacral plexus, and you put in the spacers from the front. Here you can see there is a 4-5, 3-4, and a 2-3 spacer, and these screws are put in percute or percute screws from behind. Spacers are put in first, and the screws and rods are put in second. Good option for revision cases, especially those which they are having adjacent segment disease. Old fusions, you have to go to the next level. It is avoidable without direct posterior decompression with significant central canal. So where there's a significant central canal, it's still better to go from behind and do a TLIF. But if there's an indirect decompression which you think can work, then this is the best option to do an indirect decompression where you can jack up the disc height from the front and believe that the lateral recess at the rear has been taken care of. Having covered this complete gamut of non-invasive to minimally invasive to completely invasive, I would like to share my predicament, which I've had for the last 30 to 35 years. And I read this line every day. I want you to understand what I'm saying. Tread cautiously into spine surgery, for things are changing as we talk. What is state of the art today is history tomorrow and obsolete the day after. Do what works best in your hands rather than be market driven or techno savvy. I hope whatever I've said can make a difference, even if you remember 1/100th of what I've said. What are the lessons that we've learned today? When to break the claudication cycle. Symptoms more than signs. Let the patient buy the operation. Signs more than symptoms. Counsel about the need for surgery. Elderly osteoporotics. Aggressive medical treatment first in the form of bisphosphonates, mononuclear and monoclonal antibodies like denosumab, romosozumab, teriparatide, as and when it comes, abaloparatide, SERMs, MHT, anything. Complex LCS, which I showed you, or lumbar canal stenosis plus, like scoliosis, listhesis, redo surgeries. Less is always more. Instrumentation in the elderly, augment it with cement, bone morphogenic protein, screws, and wires. Use all the technology and technique that you have. You will have artificial intelligence, robotics, navigation, minimally invasive spine surgery soon. Remember, these are patients. They will usually need a post-operative intensive care unit backup. Do not do it in lesser setups, more from the fear of general comorbidities rather than specific surgical misadventures. What is the future now? It's fusion versus non-fusion. We would like to maintain flexibility. It's a non-fusion option. Minimally invasive versus open. Everybody wants a small keyhole surgery. Instrumented versus non-instrumented. Gene therapy versus biologics versus metal. My guess is as good as yours. And in our country, something that has to be Atmanirbhar, cost-effective, and safe. And finally, I still reiterate, start with why. The purpose of the surgery is far more important than the process of the surgery, which is far more important than the product. The why is more important than the how, and is far more important than the what. Operate for need and not for greed. Operate for outcome and not for income. Just putting in screws because it adds to your personal set of series, please avoid, because they are only needed where they are needed, and when they are not, they are superfluous, and they may just not be available on a post-operative X-ray where you put them originally. Finally, I share my feelings by quoting Bertrand Russell, who said, actually inspired probably by the Dunning-Kruger effect, that the whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people are so full of doubts. What is the Dunning-Kruger effect? The more you know, the less confident you're likely to be, because experts know just how much they don't know. They tend to underestimate their ability, but it's easy to be overconfident when you have only a simple idea of how things are. Try not to mistake the cautiousness of experts as a lack of understanding, nor to give much credence to lay people who appear confident but have only superficial knowledge. Friends, behind every successful person, there are a lot of unsuccessful years. I quote Henry Marsh here, who in his book, Do No Harm, said, and I quote, "It takes 3 months to learn how to do an operation. It takes 3 years to learn when to do an operation. And it takes 30 years to learn when not to do an operation." I've always ended on this note, and so will I today. Good results come from experience. Experience only comes from bad results. Thank you all for a very, very patient hearing. God bless you.
Thank you, sir, for a wonderful session. I would now like to request the participants to put their queries on chat. Sir, as of now, there are no questions in the chat. Raj Bahadur, sir, would you like to ask any questions to the speaker? Sir, you are on mute.
Once again, I'm grateful to Professor Ramchata. As usual, he is a master presenter in orthopedics in our country. That's known for him. Dr. Chadha, this is a class for postgraduate student. I wish to tell to the postgraduate students that what Professor Ram Chadha has mentioned is a vast experience with a vast surgical skills also. So if you happen to go to the spine surgery after the DNB, probably you need to spend many years, as he had mentioned. So first of all, you have to assist the master for n number of years, say 3 years he has mentioned. And then do your surgeries under supervision of some masters again, and then you become independent. Only then probably you will be able to tread on the path of spinal surgery. So for you, I would be asking if the students, they have no question, sir, would you mind telling them bit of, although it is little away from this, something about laminoplasty in case of lumbar canal stenosis?
Thank you very much, Professor Raj Bahadur. Laminoplasty, like any word where the word plasty is used, is to do with preservation or reconstruction of the structure. Wherever there is compression in the spinal canal, the cervical, the thoracic, or the lumbar, conventionally, the operation done is removal of the compression by doing a laminectomy. However, laminectomies used to involve brutal removal of bone, making the spine unstable. This instability over a period of time caused severe back pain. Hence came the era of removing the pressure and still maintaining the structural integrity of the spine. How can this be done? Well, it is done by removing the pressure and yet keeping the structural integrity in the sagittal plane, in the interspinous level intact. Hence, what is done is that if there is a narrow spinal canal, like say like this, trifoliate, one way is that you remove the entire lamina. The other way is that you widen this and keep it still open. Hence, various surgeries more than a lamina. Laminoplasty either from one end to the other, which means that you, let's say you're doing L3 to L5, lumbar 3 to lumbar 5. There you could begin at the L5 S1 and pick up that entire lamina as one arm mass, decompress all the roots, decompress the ligamentum flavum, thin out the bone, reposition the lamina. That's one way of doing it. The other way would be just the widening of the canal and making that smaller triangle into a wider triangle. The widening and maintaining the triangle is more so in the cervical spine, while arm mass removal, thinning it down, is practiced in the lumbar and the thoracic spine. Hence, the word laminoplasty, preserving integrity and movement, yet achieving decompression, balancing the tube, is one of the best non-fusion options available, though technically demanding. I know Dr. Raj Bahadur has been practicing this for many, many years. And it is a pleasure that he has asked me this question because he has huge experience on the same. Sir, I would want you to give and share your inputs on this, please, sir.
Professor Ram Chadda, after learning about laminoplasty from Professor Tulli, we started doing this. And then the moment the screw available, they were available to us, I find that the result of laminectomy with stabilization were superior than the laminoplasty. This was my experience over years. So I would now, I'll do a wide decompression, stabilize with the implants, bone graft, but laminoplasty per se would be probably little bit inferior as compared to the decompression which we are able to do now and then putting implants with this.
So that is experience from a person who's done both and done it in large numbers. And I thank him for that because as I say, I began with an era of laminectomies and then I suddenly graduated to decompressing and putting screws, which Dr. Raj Bahadur, Professor Raj Bahadur is aware of, and we have been in touch for the last 3 decades. So that's how it is.
The next question, Dr. Ramjata, for the student is, for example, if there's a patient who has less of intermittent claudication, there's no weakness of muscle, but the decreased sensation they are there, what you will suggest to these patients? Decreased sensations, no bladder involvement still.
So let's understand that a lot of lumbar canal stenosis are partly mechanical and partly metabolic. And wherever we have absence of red flags or significant neurology, as mentioned by you, I actually correct and look for all the metabolic issues. Vitamin B12 deficiency, HbA1c, which is going out of control, any other sort of disorder which is making that person more susceptible to these paresthesia, etc. All that needs to be corrected first. And it's only after I've corrected the entire metabolic profile would I then think of doing something, probably after I get corroboration by an electrophysiological setup. If you have a good electrophysiologist with you and you have these difficult situations where You don't have gross findings on the MRI, but you still have an unhappy patient. It's only there that you would actually go for a targeted surgery. Otherwise, I avoid surgeries. I keep pushing it and delaying it till they really buy the operation. I don't believe it in selling to them. That's how I am as far as these paresthesia are concerned.
Okay, have you ever encountered a patient who is with, say, motor neuron disease, and the MRI shows the disc degeneration at the cervical spine, and somebody would have operated upon such patients, and what are their results? What would be the situation? How they will take it like that? A MRI showing cervical degeneration, clinically the bizarre picture which mimics like a motor neuron disease or a latent sclerosis, and how do we take such patients?
Sir, I'll be very frank. We never know why an index surgeon did something. But when we have a situation which comes to us where there are two pathologies staring at us, one, the obvious mechanical one, which has been addressed by the surgeon, and the not very obvious metabolic one, which was not addressed by the surgeon, or a central neurological one, which was not addressed by the surgeon, we have to then counsel these patients, handhold them and walk them through, because these are more unhappy patients than the ones they were prior to the first surgery. So counseling an unhappy patient is by itself a huge discussion. And as I look at it, I still handhold these patients. And I always stick my neck out and say that we cannot change the past, but we can mess up the present and the future. So I walk them saying that the perils of the past and the fears of the future have to be kept aside. Be pragmatic in the present, and let's walk through the present. It is difficult. I totally agree with you, but that's the best way forward.
Another situation which we encounter is a patient with a lumbar canal stenosis associated with, or certainly an old person with a Parkinsonism. How do you take such patients?
So Parkinsonism is something which is getting far more rampant, and there are variants of Parkinsonism which are not fully blown and which have really hit us. Two things I'm sharing about Parkinsonism, which I have learned after burning my fingers. One, most Parkinsonism patients also have significant osteoporosis. Look for it, treat it, correct it. And second, if you're planning to use metal in Parkinsonism, only use it if it's very, very, very necessary. Otherwise, don't use metal. That continuous mobility that they have, these implants tend to loosen and back out. So these two things have to be addressed. However, despite all this, there are Parkinsonism patients who come with genuine spinal problems, and they have to be at times addressed surgically, because Parkinsonism does not reduce your lifespan. It has bad quality life. So we have to control their Parkinsonism with the medication that the neurophysician is giving them for the motor neuron or for the movement disorder. And at the same time, we have to give them whatever limited surgical intervention with implants which are friendly for osteoporotic and aggressive anti-osteoporotic. I've learned this from my mistakes from Parkinsonism patients. They also develop a large number of adjacent segment diseases in Parkinsonism. आपने L4-5 fuse किया हुआ है, sooner or later L3-4 and 2-3 will get ecclestotic. So be prepared, counsel them from the very beginning. They are very good-hearted patients, all these Parkinsonism patients themselves. So be nice to them, they're extremely nice to you. I have found that in most of my patients.
Dr. Ramchandra, the last question from my side for the sake of the student is that the younger surgeons now, they are fancy of endoscopy. They, without knowing the open surgery, they go for endoscopy and they remove disc, or they may also say that they are able to do the care of the latent stenosis. What would you recommend to the people, those who are still the DNB student and maybe venturing into a spinal surgery?
Sir, I strongly recommend that they should hone their skills as far as endoscopy is concerned. They should train themselves, but they should not wield that weapon on every patient. It should be a training or a tool that you have access to and use it very sparingly. Unfortunately, what happens is that if you have a hammer in hand, everything looks like a nail. So you start hitting it. That's the unfortunate problem. So the moment you have a scope, you start finding a reason to put the scope in. No. Let endoscopy be one tool. So if you recollect, in the late 90s, I started doing minimally invasive thoracoscopic surgery and laparoscopic surgery. And I used it sparingly. I still use it very sparingly. I don't put that thing everywhere. So we have to be justified in using a tool, because at the end of the day, a fool with a tool is still a fool. So we have to use that tool very, very sparingly and use it where it is indicated. And my humble request to my younger colleagues, hone your skills, know how to use an endoscope, use a tube, use minimally invasive, use navigation, use robotics, you will AI tomorrow, everything. But always start with why, then the how, then the what. अगर आपके पास what का tool हाथ में है, that does not mean that every how and why has to have that what going in. Please be very careful.
How do you take if a person has not learned the laminectomy and then started doing the endoscopy?
Sir, I would be extremely skeptical about that, because at the end of the day, they have to know what is needed where. Yes, they can use that scope to do a complete laminectomy from within. I'll be the happiest if they can actually get in with a scope and do what we were doing with open surgery. But the other way around, I'll be unhappy where a laminectomy is indicated. They put in a scope, a few days later, they do a minimally invasive, a few days later, they do a complete laminectomy. So one procedure becomes 3. It's very disheartening, and at the end of the day, it makes the people very unhappy and brings our noble profession into disrepute. So we have to be very, very cautious. Humble request to my colleagues.
Thank you, Professor Ram Chadha. I think it is a privilege of the National Academy of Medical Sciences to have you for this lecture for the postgraduate students. And I am personally grateful because you have accepted my request to you, because I thought that you are the person who will be justifying this lecture. Thank you very much, Dr. Ram Chadha.
Thank
Sir,
you.
one last question. I am
Yes.
basically a physician. Are there any guidelines? Because all radiologists reported as you are born with a narrow canal. What is the normal dimensions of the canal which you take?
So there are what are called dimensions available with radiologists, and every country has country specific dimensions or diameters available. Like the canals in the Japanese are narrower than the Indians have narrower canals than the people who are living in Europe, and the Europeans probably may have narrower canals than the Americans. I'm just giving you a sort of a general consensus that this is how it works. But it's not just the capacity of the canal, it's the relationship between the passenger and the passage. Please understand, sir. If your passenger is also thinner, does not matter. But if your passenger is wide and the passage is narrow, that's where the problem occurs. And hence, we have to look at a relative canal diameter of the bony canal and the theca, or the soft tissue diameter of the soft tissue content. And if over a period of time that gets jeopardized, then you get symptomatic. Otherwise, you don't. Constitutionally narrow canals are below a mild set-off value, which varies country to country and population to population. But those are far few and far-fetched. So we don't have to get exceptionally worried about that. So it's very, very few.
Yeah. How much is the incidence in your practice regarding what cervical versus lumbar stenosis?
So
How
lumbar
common?
stenosis is far, far, far more than cervical canal stenosis. But yes, tandem stenosis does exist. And let's put it this way, that if I was to look at, and I do a cervical spine screening in all my lumbar canal stenosis patients, 25% of my lumbar canal stenosis will have significant cervical canal stenosis, which may not yet be symptomatic. Or the other way around, significant cervical canal stenosis may have significant thoracic or lumbar canal stenosis, which is not yet significant. So that's how it is. They do coexist. Hence, a complete spine screening is an integral part of our study in the elderly.
Sir, last thing, in your setup, any cases without any signs or symptoms did you operate? Only on the
I have had the good fortune of never selling an operation. And unless I am convinced that the surgery is going to benefit the patient, I don't. I've always looked at and say this very commonly to all my patients, that in the surgery, there are three beneficiaries: the patient, the hospital, and the doctor. And it has to be 90% patient, and the other 10% beneficiary have to be the doctor and the hospital. If it's not 90% beneficiary to the patient, I do not offer surgery.
Because patients are pulling on from the past 30 years, no signs, but still they want surgery. That's the reason.
Sir, I would like to look at the mindset of these patients, and the lady sitting there who's belonging to a department which looks after the mindset should be actually giving her inputs.
Yeah. In fact, I remember Dr. Choval's saying passage and the passenger, which was very fond of, and Dr. Ramani also was quite fortunate we wanted to. Thank you, sir. It was a great deliberation. Thank you.
Thank you.
Thank you very much, sir. It was a very wonderful session. It was very interesting to hear you, and I also learned a lot from you. I would now request Professor Ajay Kumar Sood, sir, to deliver the vote of thanks.
Thank you so much on behalf of the National Academy of Medical Sciences. It is indeed my great privilege and honor to thank the distinguished speaker, Dr. Ram Chadha, sir. As Dr. Raj Bahadur sir said that it was one of the best presentation, and perhaps you are one of the best teacher in the country in orthopedics. So that is a big compliment from Dr. Raj Bahadur. And I think all of us who have attended this session, we are really honored by your presence. So thank you so much, sir, for sharing your experience of several decades in lumbar canal stenosis. I am very sure that the participant and other students who have attended this session, they are really privileged and they have benefited greatly from that. So once again, I thank you, and we look forward for your blessing and support to the Academy in future also. Thank you very much. Again, Dr. Raj Bahadur sir has been great support for the orthopedic series. He has been the chief coordinator, and sir has identified the best speaker and also the best topics. So today is the last session in the series. So on behalf of the Academy, again, sir, we are really grateful to you for your support to the Academy. And thank you so much for your time to the Academy. And I know a lot of efforts have gone from your side for identifying the speaker as well as the topic. So we are really grateful to you for your support to the Academy. I will also like to thank all the participants who have attended this session, and also the questions which have been raised by some of you. So thank you so much for making this session interactive by asking questions. For the participant, especially the postgraduate student, we have two more information that from July onward, we are starting a helpline for postgraduate students in collaboration with Indian Council of Medical Research on biostatistics, especially how to help them in their thesis work. So from July onwards, we have a ICMR NAMS National Biostatistical Helpline. The details will be circulating to all the students. And second announcement again is for all the participants and the PG student. In collaboration with the IIT Hyderabad, NAMS is planning to start a short-term certificate course. Of course, it will be online on artificial intelligence and machine learning in clinical practice. So both these programs we are going to announce in the month of July. So please, we'll circulate all these details. And these programs are, especially the biostatistical helpline, we are thinking to start just in the first week of July. I would also like to place on record the support which we have been getting from Dr. Preeti from All India Institute of Medical Sciences, and she has been helping us from the very beginning in moderating and coordinating this program. So thank you so much for your help and support to the Academy. Our IT team here, Mr. Ravi and Mr. Shivam, have been responsible for sending you the Zoom links and ensuring the Zoom and YouTube transmission. So once again, I thank you all for being with us and making this evening very, very interesting and academic phase. Thank you so much.
Thank you, sir. I declare today's academic session closed.
Thank you. Thank you.